So well done, panel. I'm sure there are many questions to be asked for the panel to answer, so I'll wait. Yes, I couldn't have guessed that it wouldn't be Cindy.
My first time.
Go to it.
Giving me a hard time. This is a question for Heather and perhaps Lori, because Heather, I heard you say labeling is approved as part of the drug authorization process by the FDA, and once that's approved, we don't want to change it because we say, why, this is what was approved, don't change it. The process that Lori described was taking information, letting Ruth and Mike rewrite it, testing it with focus groups, then doing additional testing, which I'm just guessing changed the language from what was approved by FDA. So can you help me figure out how this happens?
So that's all happening before the product gets approved.
So, okay, so help me understand this piece, because the FDA has a time clock, and the labeling is like the last thing that happens. And isn't there a huge amount of pressure to get that label done in a really short period of time?
There is, and for that reason, I mean, Lori can probably speak to it better than I can, but what we've done is we've worked it into our time period. So the labeling team at Merck, right, knows that health literacy is going to be taken in, concepts are going to be taken into effect. They know that we're going to be seeking outside assistance. And so that's built into the timelines. And so, Lori has had to sort of educate folks on the teams, and she does it every time, a different team is involved. And it's really setting expectations, and folks know that they have to do it. Sometimes there's, pressure, but it gets done because it's been prioritized as important.
Very cool. Thanks.
Mary?
This is Councilor Rennie.
Yes.
First of all, you're very brave to have come. And we have great attorneys. I'm on the round table. I'm Maren Allen. And we've got great attorneys at NIH and work with them a lot. So we respect that process. You said disclaimers matter. And part of the problem, I think you used the word onus, and I think it was just the right word. Maybe I've just gotten a little more friendly about doctors since I've been on the round table about sort of what they're up against. And the reality is, and this is kind of a message to take back, is you all know the most about the drug that you've developed. You know more about it, your scientists know more about it, you've told us as much as you can about it, but the physician's role in terms of having to be responsible for all of the drugs, for all of the patients, for all of the people that they see, seems that the onus is misplaced a little. In other words, that it has to be a shared understanding between the manufacturer and the physician for the benefit of the patient. And we've been working really hard on some risk materials, and you mentioned risk in your presentation. It's probably the thing that's done least well for the audience that we're talking about. And I think that if that's a message that, Laura, you're probably going to kill me for this, but if this is a message that you can take back and talk about, I think sort of thinking about the fact that the audiences are being confused by all of the disclaimer messages they're hearing on or seeing on television that is fulfilling a legal requirement, but is not actually telling them what Januvia is going to do for them or no, I didn't. Oh, okay. Okay. Man, that was a serendipity. Or maybe not. But so I guess the plea is, can you sort of look at this a little differently together about the concept of onus responsibility to the end user, and that the system needs to be fixed, because we're back to the dyad of now it's the physician, and before that it's the individual, and can he or she understand that it's once instead of once, as they did at the National Press Club. So look at like the big system, and maybe you can do some of the exciting work that you've been doing together to make this work better.
Yeah, I mean, I guess my comment would be, we take it very seriously, and we hear you. I mean, and that's one of the reasons I think that Merck has made it a priority, health literacy a priority, because we do think that the physicians, their time is limited. And, you know, there's not everyone out there has an incentive to educate the patients on disease. And so we take that, you know, when we have a new product coming on board, and for the products that we do have, we take that role seriously. And, you know, I think we all want to do what's in the best interest for patients. And certainly from a legal perspective, I want to make sure that patients have all the information that they need to take the product safely. So,
Thanks.
Thank you.
Thank you.
The only other thing I would add is, of course, the FDA is doing studies around risk communication about direct-to-consumer and other things too, right? So I think it comes back to a theme of the need for policy, and I think it's great that you're spending and investing energy in trying to figure this all out too. Right? So, no, but I think it is. I mean, it's important.
So let me ask the panel a question that perhaps could be helpful to the roundtable. So individually, what would you think would be of value to the roundtable in thinking forward about health literate design? Be innovative. Think differently than what you said here just today. Push Lila and the rest of the team a little bit, plus me. Tell me, what would you think how we could innovate and help the future of health literate design?
So I'll rehash one of the slides I didn't get to that is more forward-thinking than work that's been done. But when I think about my experience in terms of getting the information I need on a website, I think it's really important to think, despite, you know, most of my work has been sort of at the level of a document and how to improve comprehension of a particular document. I think it's important to help people not only find but evaluate and integrate information across multiple documents in an online environment, because we know, at least anecdotally, that people are being nudged all the time by the way websites are designed to go elsewhere. And they may not remember to come back, or even within the same website, they're bouncing around looking for information. And there's really interesting work going on in computer science that kind of uses the analogy of animals foraging for food, where they're constantly adapting to the ecosystem in terms of where to look, you know, what bush should I go to, when should I leave this bush and go to another bush. And so there are theories of information foraging which are really interesting in terms of helping people evaluate as they're reading information in a particular document, to make on-the-fly assessments about have they gotten the information they needed to answer their question. And when should they quit perseverating and go elsewhere, and what can you do to help guide them to other information? And then there's lots of unanswered questions about how you evaluate people, or how you encourage people to do that integration as they're inevitably going and reading multiple documents, and how do you encourage them to integrate the information? We know older adults spend too much time reading text online. Younger adults tend to leave earlier to go somewhere else where the information may be richer, more berries in the bush. And they remember more information across multiple information sources. So you can help older adults actually extract more information from a given text by having a longer load time for another. So if there's a cost to switching to another information source, they'll stay where they are and they benefit. They learn more information. So I think there's a lot of interesting work in computer science that kind of embraces the idea of ecology of information and how it's transforming with the new media.
Heather?
So, so one of the things that Dr. Lee said that I sort of made note of, he said it's becoming harder to determine what to leave out. And one of the trends that I've seen sort of over the last 13 years being at Merck is that there has been, it used to be the physician prescribing information had sort of all known risks, that were important to communicate to the physician in it. And then the patient labeling was sort of the most important information to know. And what we've seen happen over the last probably, I don't know, maybe it's been the last 10 years, is there's been a move to put more information into the patient medication guides and PPIs. And I think one of the things that happens is then you see that translate into promotional labeling. The OPDP or APLB will require all of that information to carry over. We no longer have a concept where we're gonna limit the amount of risk that we give to sort of what are the common side effects. And I think that has had the effect of making patients, quite frankly, overwhelmed. You're telling them about sort of less common side effects, rather than saying, here are the common ones. These aren't all of the side effects that you may have. If you have anything that changes, right, it could be as simple as that. Anything that changes, make sure you call your doctor because it could be a side effect. I think that would go a long way to sort of helping patients. I think it would inform them. It would say, hey, look, there might be something that's not here that you need to talk to me about. Call me. I think that would help. The other thing I heard Caleb say this morning was that we don't do a good job telling patients why it's important for them to take their medication. And it used to be pharmaceutical companies did more of that. And we've been sort of limited, I think probably in the last, maybe in the last 5 or 6 years, there was some warning letters that came out to companies that said, hey, look, you can't talk about the consequences of the disease if you don't have outcomes data. And so what that did, it had the effect of changing how pharmaceutical companies were out there talking about the disease state that they had products for. And it meant, in a strange way, it meant less information going to the patients as a result of FDA's position. So I think we need to figure out how we can fill that void to let patients know, not only here is the condition, but why it's critically important if your physician has prescribed this medication, why it's critically important for you to take it so that you can hopefully stave off sort of bad outcomes in the future. So those would be the 2 things, I guess, that I would focus on.
Thank you. Michael?
I'm going to just say something a little bit different because I know we're talking about written material, but kind of backing into it, what do I care about? I care about helping patients get the optimal benefit of the medications that they are prescribed and to be able to take them and minimize harm associated with the medicines and helping them in the meantime also be properly vigilant so they can problem solve with their medications, then they can and also be wary of anything that may happen while they're on the medicine so they can reach out and seek care necessary. So from that end, I think there's a lot of innovations that, or I don't know if you want to call them innovations, just things that we can do. Like, I don't think it's innovative to, I don't mean it in a negative way, to say that we can disseminate and on a patient portal provide them with good content. I think these are things that are just there that we should be doing already. If we could just get past some of these hurdles about figuring out how to just implement and disseminate some best practices. I think what I'm coming to with health literacy in focusing on safe medication use and adherence and as with any kind of self-care behavior is we need to think bigger. We need to have unfortunately, I think we're going to be in a position that we really need to have more provider engagement, whether that's a care coordinator or a pharmacist or an allied healthcare provider in any kind of way. We need some way to have ongoing relations with patients between encounters. And maybe we even start by focusing on those who are at greatest risk, those patients who have a lot of medications to take. And from that end of it, I'm hoping we can be very creative, the roundtable can be very creative in thinking about how healthcare is being redesigned and repackaged, and again, what the future might hold with value-based care models, anything that, if it keeps going, or I don't know what's around the corner, but Will Schrank alluded to this before, that no matter what happens, there is increased demand for linking anything, any interventions, any strategies. We're all compelled to involve patients, to engage patients in their care, because it comes down to cost. So because everybody is motivated, we should be thinking beyond very passive, very discrete forms of just the disclosure of information to learn about your medicines, but we really need to link that, I think, to thinking about this in a continuum, that it's not a one-time educational opportunity, but how do you front-load the education when people want to make it because they're about to make the decision, should I take it? Because once you've accepted to take the medication, then I think it's about supporting the behavior and helping them become more informed over time, but also prepared to problem solve with the medicine. So I think we need to think of what are the goals across the trajectory of taking medicine, from the moment of it choosing, is this the right treatment for me, to agreeing to it, to initiating it, to persisting with it.
Jennifer, were you...
Jennifer Dillahay with the Arkansas Department of Health. I really appreciated what Dan had to say. I trained as a geriatrician, and I recognize that here we have a group, a large group and growing group of Americans who are not likely to improve greatly in their own health literacy skills. So then it becomes incumbent on their families to gain the skills to support them, or the health system. And I think Mike alluded to the patient portal, because that's how many family members and other caregivers get the information they need about the older adult patient. And I would be interested, Dan, if some of this internet work that you've done can be applied to patient portals. Has it been, or is that on the way, and those kinds of things, that we can use that information to improve those kind of linkages?
Well, that's another slide I didn't get to. So, yeah, in general, one thing I worry about with technology-based innovations is that more information is raining down on us. And I think that might be true for patient portals. If you look at the literature about who is less likely to use them, there's a lot of evidence that older adults with low health literacy are less likely to sign up, or if they do, they don't explore the functions, or they get confused. And I have a patient portal. I'm an older adult, and so I have a project that's going on, and it's driven by, I think, part of my frustration about using my patient portal to understand clinical test results. And it's just abundantly clear that the best practices that we've been talking about all day are not being used routinely in terms of designing the information that are on patient portals. So we've been doing some work, and we're not the only ones by any means, but we've been doing some work in terms of trying to help patients, older adults, better understand the risk implications of numeric information from test results, cholesterol. And so when I log on, it's a table of numbers, my HDL, my LDL, my triglycerides, and I think the expectation is that I may browse that, and then I'll go to my physician to get a better understanding of what the gist is. But patients may not do that. It would be much better if the information was in the portal in a way that was more accessible cognitively, easier to understand. So we're doing some research on better graphical representations of cholesterol test results that allow people to extract the gist of what's the level of risk associated with the components and how do I integrate them into kind of an overall picture of what my risk is given that. We're moving towards, in the spirit of Brian Jack and his work, we're moving towards developing a conversational agent interface so that you have a interaction with a virtual physician who will provide kind of a high-level commentary on the information. The idea is not to do an end run around face-to-face communication with your doctor, but to kind of help bridge that gap. If I get the information after seeing the doctor, I may be able to engage in an interactive. It may be graphic, and linked to a conversational agent's discussion about what this means for me. That hopefully that primes me to then go to the physician who has limited time with a more focused encounter.
So you're suggesting then that like having clinical decision support on an EMR, we have patient decision support? Right. Katina.
Hi, I'm Katina O'Leary. I work at Health Literacy Media. So I was listening to some of this conversation and sort of thinking back about the early parts of the day where we had sort of a people-patient experience part. And I was thinking about some of the things that you said, Mike, about sort of this provider engagement piece, which we sort of heard now and again. I mean, I think I heard you say that multiple forms of information and providers being engaged was the best way to make something happen. But we sort of don't know maybe as much as we should about that. And when we try to do that work, I don't see providers get really excited about being part of experimenting on themselves or changing their behaviors or sort of really digging in to do that differently. I kind of see and hear a lot of conversation about how hard it is and how hard the system is and how complex it is, and sort of we focus on the same things over and over again, and then we kind of are not happy when those things don't happen. We keep hearing things like written materials don't really work, and sort of the theme is sort of low-hanging fruit, and that kind of goes on and on and on, and I hear that at a lot of these meetings, and it's a little bit frustrating. And then we hear patients say things like they said this morning of they're even using our language. They're talking about adherence and compliance and what this means to them, which is sort of a funny thing. So it's really hard, and they've adjusted and they've learned all this stuff, but they're still not doing it well enough, and we think it's our fault, but we're going to study something else. And I just can't quite figure out how to break this. I don't know how to disrupt this system, and I'm not hearing a lot of solutions. I'm hearing kind of a lot of problem. So I just would like to talk about that. I wonder if anybody else heard something different or have any ideas.
Can I just say something on that? So I agree. I'm tired of it. I'm tired of coming to meetings at the FDA, at the IOM, at any other institute, in hearing stuff that I feel like I've heard over the past 15 years. I'm sick of it. I'm sick of going to multiple meetings at different agencies and feeling like I'm having the same conversation over again. And I think that's part of the frustration. I would also argue, I think there's one solution that I would recommend on the spoken counseling piece, because it is stagnant, is, so one of the tools that we talked about with it's called EMC Squared, is we are trying to provide counseling support, and we are giving best practice alerts, which we know there's a lot of evidence in terms of pop-ups drive prescribers nuts. But how do you do it? Let's even target the medications, the 65 to 70 medications that may have an active REMS, risk mitigation strategy, as identified by the FDA, if they have an active plan in place. And just start with that. So there's a little bit of a spotlight effect on the highest risk meds. And you put best practice alerts into the EHR that kind of notify and even give, here's the plain language information of the most important one or two things that we want you to say to this patient before you proceed to order. And what we're working right now with in that system is to say, if we are providing the support and we have data that can advance to it, do we ultimately get a signal of whether or not they prescribe it? Could, in fact, we track counseling in a way through these BPAs, through the EHR, to identify and even provide feedback to providers to suggest, over the past 3 months you prescribed X number of high-risk medications and you counseled X% of the time. Could that not be a quality indicator then? Could you not have a means to find some ways, and again, that I know all the challenges, we've worked through that in multiple EHR platforms, but how do you find a means to hardwire this place, but also hold accountability? And I wouldn't say it's just for the prescribers. I think patients need to be held more accountable as well. I think that we have to recognize, especially if you have 5 or 6 or 7 medications, and that's very common for a lot of our patients, for me to say, you know what, I'm going to ask you, between visits, because I don't want to wait 3 months before you come to find out that you've been really misusing your medicine or you stopped taking a medicine without telling me, which could have some severe consequences to your health. I want to know. And could you just, report back in through the portal or through a phone call, an automated phone call, or whatever it may be, a platform of your choice, to let us know how you're doing. And if it takes 1 or 2 minutes or 3 minutes, even if it's every 2 weeks or every week or even once a month. I mean, I think there are changing roles that I think we need to create a more connected system. And that requires a little bit more from patients and a little bit more from providers. And our health system, though, does have to create the window of opportunity. Can we still work within 15 minutes in a managed care system? I mean, all those things are kind of on the plate. But again, pie in the sky.
So I get that, but I would say a lot more from providers maybe. I hear patients doing a lot. I hear them talking about sort of doing a lot in the context of being really sick, which is sort of foundational in health literacy, right? Like the concept that you can't do the cognitive things you have to do when you feel really bad, and we're saying to kind of amp it up. So, in a balanced way, I would like to say that. And the other piece of it is I appreciate everything that you said about efforts and interventions that you're studying, and the counts are great, but if we don't know what they said, we don't know that the counseling works. And so how do you get it into medical education so that they do it well?
Yeah.
Because the fact that we think
gaps.
people are actually doing it well and providing the information in a way that's understandable and accessible is sort of...
Yeah, I mean, that's where I think we started spiraling, because you've got medical education, you've got issues on how do you get people to actually counsel, how do you give them the training wheels. What?
Remember when you said think big?
Yep, no, you're great. No, you're right.
Jay?
Thanks. Mike, first to your follow-up on your big idea with that idea of meeting some of the patient needs that we heard this morning as far as increased integration, increased contact, working through, increased number of between visit contacts and all these other things. There's outcomes data that works. We have that through, so I completely agree, and I just want to share this as validating. So through things like the Humira, as Ed Israelski mentioned, the Humira Ambassador Program, all these other contacts that we have. AbbVie has several hundred nurses that are trained in cultural competencies to do these type of things. The trick is, I don't know how you do it on product support when you don't have a product that makes more than $1 billion a month. I mean, it's just, and that's just the reality of the thing, that when you have that type of access to resource, it opens a lot of access to resources, but I think it's still having that good idea. It's the reproducibility, so that becomes so difficult. So with kind of going from that towards, where do we go next, and to your the comments you just made, but also for Deanna and Heather, where does health literacy continue to grow? So because now I think that, we've looked at it from prescription and confusion, and then coming through this, and in particular with the idea of the changing patient experience on the basis of technology or increased uses. Dan, you were describing information foraging and how these are just naturally very different when we have, they're different in the access to resources and the potential impact of them, but capitalizing on that potential. So my question is health literacy the goal to remain continuing an add-on? Is health literacy something that is there value in looking to develop in the ways that something like outcomes research has been developed, where we're going to start having graduate programs that are specifically focused on health literacy, that will have wide-scale meetings on health literacy, because there is that outcomes component. And right now, as Lori highlighted, out of all the major pharmaceutical companies, we're really only aware of 2 people that have health literacy officers that are saying, okay, this is it. And that seems to be in such contrast to the fact that we do have data around these particular sets of practices and disciplines, demonstrating an impact on the patient experience. So just wondering if your thoughts on that, but Dan and Heather, yours as well.
So I think that I view health literacy as and I think many people do, I think it's a dynamic field. I think that the beauty of health literacy is it has 9+ lives, because there's really it's it's a colleague of mine, Stacey Bailey, about 9 or 10 years ago, I feel right at the beginning when we started to work together, asked me the question if this was just going to be a flash in the pan. And the way I interpreted it back then, and I still hardly believe in it, I said, I don't see how this will ever fade out. It may not be called the same thing. It may change, but in terms of appreciating the user experience, which I think that's why there's so much synergy when you talk about human factors research, what's in cognitive psychology, what's what you learn from education, and people who are designing learning environments and so forth. I think there's just this idea that we want to simplify and support patients and engage patients. So right now there's this new buzzword, or it's not so new, but it is just increasingly becoming popular in terms of patient engagement, and we need patient engagement tools. Well, I think that we need to constantly be maneuvering ourselves to make sure that we are in those conversations. And I think people criticize us as a field because we do feel like we are the sum of many other parts, and we are somewhat kind of Frankensteined in from many different kind of fields in a great way, though all towards this one focus of really getting people informed, able to make good decisions in healthcare, and appreciating the health system's role in causing complexity. So I think that from the standpoint, yeah, it does. Maybe it does need a field. I don't necessarily. I think, for instance, with Michael Pasteur, although I think HARC is great, I think it's as important that we participate in other, public health, American Public Health Association, Society for General Internal Medicine, Academy Health. We need to be in special interest groups and representing there as well. That's as important to having a lot of international societies. I think that's great, but I think we also just have to recognize that we're part of a bigger picture. And so from that, I don't know if I'm really answering your question, but yeah, I think it's important. Yeah, I think it's great. I think it's something that we should be working on. I think that in terms of its ability to make the next steps, I think we have to think beyond what we've been considering as our base product. And I said this at the HARC keynote when I gave it and Cindy gave the other one. I don't think many people appreciated the Mad Men talk, but the notion that I was saying their base product is simplifying material and making information accessible to people, and it feels maybe like we want to be more, and I think we should, but we haven't really done that. We keep talking about, and people keep thinking that as health literacy, oh, you're the people who make things plain language. That's an incredibly important piece that we'll never solve in the next 10 or 15 years, but we have to start thinking bigger, that we are about patient engagement. How are we using better information to engage patients, to make them care more about their, and yet we are a behavioral science. That's what I think, not just an informational science. And I think that's something that we oftentimes spend less time talking about, if that makes any sense, and we should be talking more about it. So.
Any other comments from the panel on that question?
Let me follow up. Jay, I'm getting a sense of deja vu here from listening. It reminds me of the discussion, ongoing discussions, but for decades, about human factors. And so how do you infuse human factors into organizations so that people are breathing the concept of that it's an embedded competency? And then the FDA has led the charge in terms of federal oversight on that, and it's an ongoing process. And so I get a sense of health literacy kind of having the same the same status in terms of how do there's a lot of work now on health literate organizations, so how to make that work more systematically, and so it's in the water being drunk in organizations and part of medical education.
Yeah, and I guess the one thing that I would sort of add is that social media, I think we still are trying to figure it out and what that means. I mean, certainly in the space-limited character platforms, you're going to have to keep it simple if you're using it. The question is how does industry and other healthcare providers, how do they use it to their benefit? If you look at the statistics, I think I read something where something like 18 to 24-year-olds, 85% or 90% of them, if they have something that's wrong with them, their first thing they do is go do a Google search to try to figure out what's wrong with them. They don't call a healthcare provider. They go on to Google and try to figure it out. And so, as we sort of move forward, social media, I think, is going to play a even more significant role. And I think one of the things that we're all going to have to figure out is how do we help ensure that folks who are going on to social media to get answers, that they get accurate, complete, not misleading information, because I don't think we certainly haven't figured that part out yet. So
So let me thank the panel once again.